We're really facing a youth mental health crisis in our country and to some extent across the world. We're seeing increasing rates of depression, anxiety, suicidality, substance use disorders. If we include all of these conditions together, it's true to say that 1 in 5 youth meet criteria for a mental health or neurodevelopmental condition. And of that 1 in 5, only 20% of them ever see a mental health provider. In terms of trying to understand why and what this is about, the truth is we're really still figuring it out. There are some things that are obvious correlations, like use of technology, screens, cell phones, tablets, but we don't really know what the mechanism is. So correlation does not equal causation. We certainly see kids, youth, and adults absorbed in technology, but what's the mechanism? Is there something about the interface with the screen itself that impacts our nervous system or our reaction to stress? Is there something in the content of what people are reading, including acts of cruelty, bullying, that can happen and sometimes be unrelenting and horrible? There can be exposure to traumatic things. It's not unusual now in my clinical practice for me to hear teenagers tell me that they've witnessed either live or recordings of people making suicide attempts or completing suicide that they've streamed on Facebook or on other media sites. And then the thing that I'm most curious about that strikes me as likely component is lack of social connection. It's that the time spent with the screens and engaging electronically is replacing time that would be spent with people. And that change in the quantity of time and the quality of social engagement certainly has an impact. Of course, of the things I've listed, it's probably true that all of them are relevant, and which one is most or the one thing is really impossible to say at this point. I do think that's all related, from lack of ability to discern social cues and have successful social interactions, which then reinforces in someone that they're not good at this and to be more likely then to engage with technology rather than real people, to less touch, less physical touch. And this is something that's been known really throughout the history of man and documented and looked at by psychologists and by medical professionals, that human touch has an impact on us across the lifespan. And so less touch, less physical connection absolutely impacts children as they're developing. When we talk about brain structures and functions, right now the state of our science is usually involving some things are identified, and then by implication we predict neurologic and structural changes. The truth is we're still trying to understand that. There's some things that we know. We know that the quality of interaction with a mother during nursing, for example, impacts the levels in both mom and child of certain hormones and neurotransmitters that are produced. That's known. What that really means for brain development down the road, there's strong implications, but our knowledge is still evolving. And in fact, the research that's going on right now to look at that is really impressive, and I do anticipate within the next 10 years we will have more real data about structural impact of different life experience and different social and psychological profiles. The ABCD study, which is a national study that University of Rochester is one of the sites for, is an example of starting with children, doing a variety of assessments and neuroimaging, functional neuroimaging, to not only get the structures but the activity of the brain, and then repeating it every 2 years to really, with a large cohort, with a representative population, to see these kids who are a representative sample, so some with diseases and problems and some with none at age 9 and 10. As they grow, we expect the same rates of things like anxiety, depression, substance use disorders that happen in the general population. The same rates will happen in the study population. And then we'll be able to see how are those brains different, and really start to answer some of these questions. When someone's in an active opioid addiction, there's a number of behaviors we see that are concerning, and depending on your point of view, they're the most important things to be aware of may be different. If you're a clinician trying to make a diagnosis, then we look for drug-seeking behaviors, physiologic symptoms and changes of withdrawal, and there are pretty reliable things. But if you're a family member, if you're a friend, the most important thing is that the person will seem different. Now, there's some themes: isolation. If you are traditionally involved in social activities, the social activities with that person, the social activities tend to evolve and be more centered around drug use or drug-seeking behaviors. But the change, possibly being more emotionally reactive, possibly just being more isolative and less available, is really what's important. And if you have someone in your life that you're concerned about, you should be curious when there's a change. If someone seems more moody, more emotionally reactive, more isolative, you should wonder why, and you shouldn't really be satisfied until you have an answer, even if it's not a perfect answer, right? And you should ask, I notice things seem different. What's going on? When people use opiates, they're very powerful medications that impact our nervous system in a few ways. There's an immediate effect of stimulating specific receptors that leads to some of the feelings we experience, the pain relief. Sometimes people feel side effects like nausea, but those immediate effects of taking the medicine. But part of what also happens is it activates our nervous system to make more of those same receptors. In a way, we are genetically hardwired that when we're exposed to opioids, for our nervous system to need and want more to get the same effect. So from, if not the first dose, very soon, first couple doses, our nervous systems actually change to require more drug to get the same effect. So parallels can be made to other diseases, and ideas like insulin resistance have been raised. It's not exactly the same mechanism cellularly, but the idea of a change in the way the cells respond to either the drug or to hormones leading to needing increased amount, that is certainly the same. If an opioid addict is going through withdrawal, to an observer, some of the things that will be most obvious will be irritability. It could be emotional reactivity, meaning they don't necessarily start angry or irritable, but they overreact to the littlest thing. You can see more isolativeness. Certainly, if the fact that they use opiates is known to you or in the open, talking about it more and seeking it. Physiologically, people can also experience pain. Abdominal pain is not unusual at all. If someone developed their opioid addiction in the context of a pain disorder they already have, those symptoms being much worse could be part of the feature. Sweats, feeling weak and tremulousness, these are all things that can happen. For folks who want to get off of opiates, that know they have a problem or suspect they have a problem, this is really a serious issue. And the nature of opioid addiction is such that even a well-intentioned decision may not be enough. So my first recommendation is to do it with medical supervision. And that could, this entry point to that could be peer support through a NA group, or it could be going to a substance use disorder clinic or service. But essentially, this is, if someone has a physiologic opioid addiction, this is going to be hard to stop. There are medical treatments to make it easier and to help people get through it. And that, my main recommendation is this is hard, don't do it alone. In terms of overcoming addiction, there's multiple phases to this, but there's also common themes. So the detox or getting off the actual drug may be a unique phase that needs to just be focused on. Again, perhaps with medical supervision, transitioning off the medication or the whatever form of opiate the person's using. Then, in terms of recovery, having group support is often critical, and if the support is coming from people that are important to the person themselves, that's all the more powerful. Now, sometimes people make new relationships through treatment centers, through NA, or through other groups, and that can become powerful as well. I mention it as distinct because sometimes when you start those programs, the people you're with are strangers. In the long run, the common themes are, for success, are having a solid medical plan to deal with any physiologic symptoms, either related to addiction or to the medical problem that, again, if you started using opioids because of a medical condition, then having a solid plan to address that. Also, having supportive people in your life. This can be family, this could be parents, this could be a spouse, or again, it could be peers that you've met through treatment. And then having a meaningful activity. And this could be through work, this could be through employment, or it might not be related to how people make their income. It could be through volunteering. It could be through being a sponsor oneself in NA or in another program. It could be through working in or starting some other sort of not-for-profit or community work, whether it's about addiction or about something else. But that idea of having something meaningful that you can really spend your energy on and know is important is just so critical to success. So the University of Rochester Medical Center, or UR Medicine, operates a large substance use disorder service called Strong Recovery. And we provide services from adolescents throughout the lifespan. And it's a multimodal approach to treatment. So there's lots of groups as well as individual therapies and physician-assisted or medication-assisted treatments to meet people's full scope of needs, including helping identify what people's passions and what meaning we can find and help support them in identifying and working on. Single interventions to scare people don't work as fixes. In a perhaps counterintuitive way, you'll see people like myself and some of the folks undoubtedly in this documentary with me who will participate in information sharing that might seem like it's to scare someone straight. But really that type of thing is only useful to get someone's attention. As the only intervention, people don't really get scared straight, and it's not because they don't want to, it just doesn't work. So standalone interventions to just tell people or scare people don't work. Even a medically supervised detox without aftercare is unlikely to be effective. Not that it's not that the medically supervised detox by itself is a bad thing. We just know that without continuing support afterward, relapse is very likely. And so, while I'm not sure I would put this as a clear "this doesn't work" answer, in terms of what does work and is important to remember is that if you have an addiction history, even if you're doing very well and you don't need to spend a lot of hours in active treatment, you should still have a clinician in your life that you can go to should your life change, your life circumstance change. That could be your primary care physician. It could be a sponsor. It could be a chemical dependency therapist or treatment provider who you've known, but you don't see them regularly, but you can call them if you need to, or see them every few months. The idea of saying this is done and it's behind me and I never have to worry about it again, that doesn't work. Because, again, not because the treatment up to that point was bad or the person isn't accurate in assessing how they're doing today, but life changes. New stressors come. And unfortunately, while it isn't nice or isn't fair, if you've already have an addiction history, and this is certainly true for opiates, it's also true for other forms of addiction, when new life stress, chaos, loss of a loved one, traumas come, your nervous system, your body is going to be wired for relapse as a reaction. And so that's continued support, even if it's not spending a lot of hours per day or a week, is really important. So in terms of thinking about this from a city or a county or a regional response, things that we can do as citizens and as government is being aware of what resources people can be connected with when they need them. And again, there's different phases and different points of contact. So if we think about opioid overdose and opioid-related deaths and how we can intervene for that, having Narcan available and having people be trained to use it, and really the training is easy to do. We had a conference recently where during the course of a 3-hour conference, 100% of the attendees were trained and went home with Narcan. This is something that anyone can do, and if we think about a facility like the one we're in right now, if someone was to have a heart attack or to pass out, I know where an AED is, and I can, I'm trained to do CPR, and I can bring the AED. The truth is, in 2019, it's much more likely that I would find someone unconscious who needs Narcan than who needs an AED. Now, I have Narcan in my bag, and I carry it with me. And I think all of us should think about, if you don't, should you? Or should you know where it is? Should every library, every facility should have Narcan available? We should also have places people come in common contact. This could be libraries, this could be schools, this could be calling 911. Should be able to give folks information about where they can go for detox when they're ready. Because the reality is, people, when they're at a point where they're open to detox and to change, it is a limited window of time. And if the response is, well, good for you, I'm glad you're making a change, someone will call you in 2 weeks, it's not going to happen. We need to have a system of making sure that when people ask for help, they can be connected. And this doesn't mean that everyone who answers every phone has to do a detox. It just means we need to have comprehensive information about what's available, where, when, and it has to be regularly updated. And our county Department of Public Health is really working on doing that. Right now, all chemical dependency or substance use disorder treatment is voluntary. And so it's probably not surprising, if you just think about it, if we're relying on someone whose nervous system is so controlled by this addiction to then require their full informed consent to treat the addiction, that's often quite challenging. And so the idea of being able to, for someone who's at extremely high risk, with careful assessment and thought, treat those folks or begin their treatment involuntarily, at least to return them to a point of competency to be able to make an informed decision, certainly would be helpful and more rational than what we do right now. Well, we're actively working on opening more treatment beds. This is something that is complicated by funding. These kind of services are traditionally not things that are the most lucrative for health systems to invest in. But this is such a big problem right now that we are responding with trying to increase capacity. I have to acknowledge that I'm not someone who's reviewed the data about needle exchange programs and how they've evolved over time. I can tell you that the idea of people bringing their behaviors more in the open so that someone can approach them and talk about options to make changes in their life, potentially to address their addiction, as a general principle is good. I also have seen in our parks and in some of the communities within the city of Rochester just a preponderance of needles in the grass on the streets, and I don't really know how the logistics of needle exchange work, or if that contributes, if it would help decrease it or not. But I have a lot of concerns about the proliferation of syringes and needles in our community. My own experiences with Project TIPS. This is something that is organized by Rochester City Police Department and Camp Good Days and Special Times, and we pick 4 sites a year that are highly impacted by violence, and we canvass the neighborhood to talk to people about their community, about their relationship with law enforcement, and then there's a picnic at the end of the day with services and a variety of things to help folks in the community. We've been doing this for a number of years. In the last couple of years, some of the parks cleaning up the needles before the picnic has become an added major endeavor that we need to do.
Do you see this trend slowing down anytime soon in terms of usage versus overdose versus death? I know because some people are saying the deaths might be going down or plateauing at least, but the overdoses are going. But the only reason the deaths are down is because of the Narcan.
Yep.
So we got the usage, the overdose, and deaths. What trends do you see?
Well, I think that dividing it into usage, overdose, and death in terms of trying to keep track of numbers and rates does make sense. We have early indications of a decrease in deaths, which is a good thing. We then have to ask ourselves, is that a decrease in overdoses, or is that just more successful use of Narcan? And it's probably more successful use of Narcan, especially since if we're successful in training more people in the community to use Narcan, and they're in a situation where they use it before they call 911, and the person wakes up and seems okay enough, they may never call, and that overdose might not be detected in the current way that we count things. So I think the early signs of decrease in deaths, that is good. It's a good thing. It's probably more about our response to the overdoses than a change in the phenomenon. Now, in terms of what's happening overall, I do think the increased awareness, the increased mobilization of resources from county public health to state and federal initiatives to our healthcare systems, increased mobilization of resources to address opioid addiction is a positive thing and will have a benefit, but I think it will take a while to see that.
What would you say to someone who is currently in active addiction?
If you recognize that you're in active addiction, then you recognize that this is a problem. And I think that you should tell someone. And if you have someone in your life that you can talk to honestly, that may be the right person to start with. If you feel like none of your loved ones are someone that you could share this with, you can talk to a medical provider. If you want it to be someone you know, start with your primary care provider. But you can also contact a crisis line. You can contact an emergency department to get linked with appropriate services and help.
What would you say to family members of someone who is in active addiction?
For family members, I would say that addiction is a very challenging disease that can also be devious, meaning there's a tendency for the person themselves struggling with addiction and for family to want to see things as better or good enough before they really are. Denial is a very powerful aspect of addiction and the phenomena around addiction. If you recognize that there's an addiction problem or you have a strong suspicion, really seeking medical help, substance use disorder specialty help for assessment and for intervention, and then following through in the long term. Not just accepting that it was a problem last week, things are better today, so we're done, but realize if this was a significant enough problem to need medical or formal substance use treatment intervention, then it's enough of a problem to keep checking in about that and having some connection with support in the long term. Well, the first thing I would say to a family member who lost a loved one to addiction is how sorry I am for their loss, because it is really a significant, horrible thing to go through. And I say that not purely in the abstract. I have family members who have struggled with addiction. I have a best friend who lost a close relative to opioid addiction in a completely unexpected way. So and certainly in my clinical work with patients, I've talked with people who lost loved ones to addiction. So the first thing, again, is to express how sorry I am for this loss and recognize that it is a significant loss. In terms of the future and going forward, trying to still remember the person separate from the disease is often important and valuable for people. And trying to find new meaning in what you can do with your own life going forward to honor that person's memory. Yeah, so there is a siloing that has developed over time where substance abuse treatment centers and specialists tend to want to just focus on substance use disorders and not other mental health conditions. And traditional psychiatric or mental health facilities don't treat substance use disorders. There's a number of ways in healthcare that this kind of siloing around diagnosis and specialties can happen, and it has unintentionally been made worse in states and in regions where there's more regulation and separate regulation. So in New York State, for example, we have an Office of Mental Health that regulates mental health facilities and a separate OASIS office that regulates substance use disorder treatment facilities and provision of care across the spectrum of levels of care. The best care is clearly to be integrated, is to have, certainly at the assessment phase and ideally throughout treatment, have an integrated approach to care where all mental health conditions can be recognized and either direct provision at one site or linkage and collaboration across multiple sites can occur at the same time. That's clearly what leads to the best outcomes. And if you imagine being in the situation yourself, or just think about it for anyone, if you're struggling with depression or any other emotional condition, and you also have an addiction, if you try to address one without addressing the other, it just doesn't work. Now, you still may have to prioritize, right? Detox may have to come before, exploring the conflicts that led to depression. But that doesn't mean you don't talk about depression. It doesn't mean you ignore the fact that it exists. You still need to be aware of and have a plan that encompasses it all, a holistic approach.
Do you think they're getting closer together?
And I do believe that health systems and providers generally are moving toward that holistic approach. I can tell you that within the University of Rochester, our Strong Recovery Treatment Center is all about that holistic approach. The main site is co-located with our largest community mental health center and with a primary care service. So we're not only trying to provide care for what we might think of as traditional mental health diagnoses, as well as substance use disorder diagnoses, but also general medical health, all in one site. Part of taking a holistic approach to care also involves understanding a person in the context in which they live. And that doesn't just mean their address and what neighborhood they're in, it means their family. Now, we certainly see people that, depending on their phase of illness and phase of life, they live alone and don't interact with their family. Okay, but that's actually not true for most folks. They have important people in their daily lives, whether they're living with them or not. And within a family system, addiction impacts everybody. And so whether we think of it as formal family therapy or just assessing the whole family and supporting them, being aware of the full context of the environment and the family that the person lives in, helping understand how each of them are impacted, and then supporting everyone is critical to good outcomes in the long term. We can see, if you don't do that, we can see things like other addictions in the family that go unrecognized, right? One person becomes that's the person with the addiction problems getting treatment, and the others don't. We can see things where people who have been hurt by behaviors or also been traumatized by some of the same things that have happened to the person who's the identified patient, if you will, with the addiction problem, are suffering themselves. And if we looked at the whole family together, we'd be able to identify that and support them. So again, looking at the person's whole context is critical for that individual person to have a successful recovery. But it's also critical to help the other people that are impacted by the addiction and by the type of traumatic events that led to its cause. Yes, so while we're certainly facing an opioid crisis, and we're also facing a youth mental health crisis, and they are related, I also believe that as a community, on the whole, we are responding to it. And I believe that everyone can be part of that response, part of that solution. Consider training and carrying Narcan. Definitely think about the people you care about, and if you notice a change in their behaviors or emotions, ask them how they're doing. And really listen, be open to their response. And have some awareness of how to get help. And right now, even if all you remember is call 911, our 911 dispatchers in our region, across this region, can connect people with crisis hotlines if needed, or direct them to emergency departments if that's indicated, depending on the situation.